Welcome to the Love is the Cure Foundation podcast. I'm Alfonso Vega.
And I'm Lyndell Vega.
Our goal at the Love is the Cure Foundation podcast is to have conversations that are valuable to families as they go through their own pediatric cancer journey. When our son Inigo was first diagnosed with cancer, we were given a list of available resources. At that time, we were unable to utilize those resources. This is why we created the Love is the Cure Foundation podcast. Our aim is to offer families an understanding of what their journey may entail when their child is diagnosed with cancer, including inpatient and hospital interactions and outpatient care. Today's conversation is with Kate Matson. Kate Matson is an accomplished medical professional. She is a neuroscience, neuro-oncology, pediatric nurse practitioner at Boston Children's Hospital. Sounds like a mouthful. When we first arrived with Inigo from the intensive care unit onto the neuroscience floor, Kate was one of our nurse practitioners. At that time, there were 2 lead nurse practitioners on the neuro-oncology floor, and we appreciate both of them immensely. Kate and her team did an incredible job informing us during our journey. They would include us in the daily medical rounds. They helped guide us in our decision-making process for the few decisions that we got to make. They gave us answers to our never-ending questions, and they calmly helped us navigate through our entire journey with Inigo. Kate would link into our concerns and would research and give us an answer when a deeper response was needed. Her meticulous note-taking is a goldmine for parents like us. Kate would sit with us as our journey with Inigo neared the end. She seemed more of a friend and a kind heart to us than part of Inigo's lead medical team. She made us feel special and cared for, and it is one of the reasons that we appreciate her so much. The manner in which she informed us and included us in the decisions being made is appreciated. Kate is special to us. She works tirelessly daily to help families and children as they go through their pediatric cancer journeys. No doubt a very difficult position and a very emotionally heavy position, but Kate does it with aplomb, grace, wisdom, and if you're lucky, you get to hear her beautiful laugh. Inigo loved Kate, and the last day that he was awake, Inigo called her back into the room because he wanted to speak with her for a while. And we remember because we hung on every word he spoke. They ended up having a long conversation, and though we know that Kate needed to leave, she did not. She stayed with him, and she listened to him, and they had a back and forth about all sorts of things. It is a memory that will forever be etched in our hearts. Based on our experience, our nurse practitioners have played a crucial role in establishing the foundation of our medical team. We believe that this sentiment strongly resonates with all families facing the challenging journey of pediatric cancer. You will have a lead oncologist, and then you will have rotating oncologists, but it is the nurse practitioners that will then put the plans into motion. They will inform your nurses, and they will inform anyone from that point onwards about what the guidelines will be for your child's care. They are very special people. As you begin your journey, or if you've been on this journey, the nurse practitioners will be the champions of your cause, and in very many cases will lead you through some of your most challenging days. Well, Kate, after all of that being said, welcome to the Love is the Cure Foundation podcast. We are thankful to speak with you today.
Well, thank you so much for that kind introduction. And I'm so happy to be here. And yes, Inigo and the both of you are beyond special people to me. I don't think I've quite ever met a family like yours. And you really have a special place in my heart.
Oh, thank you. The honor's ours, Kate.
Yeah, Kate.
We're so happy to have you on with us today. So for our listeners and our viewers, we should start by going back to when Inigo and you and I met Kate on the neuro-oncology floor. What we had just left the ICU with Inigo. We'd probably stayed there about three and a half weeks. And Inigo was finally in a better place where he could come to the medical floor. And, at that time, Inigo was still very deep into posterior fossa syndrome, like we've discussed before on previous episodes of our podcast, he still could not make any voluntary movements. He could move, but, he could not follow any commands. We later found out that he could not see very well, but he did have his laugh. He had that. And we just ended up in a place in the neuro-oncology floor where we felt like, okay, we have all these questions after the last 3.5 weeks. Now we're in a place where this is their specialty. So we had a ton of questions for you and your team, Kate, specifically.
Absolutely. And so before we go into all of that, Kate, do you want to introduce a little bit of what you do in particular in your position at Boston Children's Hospital? I know I've said a lot, but I know you have more to give.
Sure. Yeah. Well, our nurse practitioners on the neuro-oncology service essentially run the neuro-oncology service. We don't have residents. We do have a neuro-oncology fellow for part of the year, as well as a first-year fellow who rotates on a monthly basis for a few months of the year. But like you said, the nurse practitioners provide the continuity for our patients and really for our team. And we are responsible for the day-to-day, hour-to-hour things with all of our patients, from pre-rounding to placing orders to ordering chemotherapy to following up on, lab results and imaging results. We do that all, as well as, collaborating very closely with the nurses and our families, trying to create that comprehensive team.
Kate is your first line of defense on that floor. And the wonderful thing is, as Lindy was saying, as parents, you arrive onto that floor and you have a lot of questions. And the nurse practitioners, Kate in particular, they are there to try to answer those questions in the best way possible. And that's what Kate did for us. And they're also there for whenever you have concerns. Rounds have already happened. The medical team is gone. The oncologists have gone back to their services, wherever they might be for that particular day. When you have concerns and you reach out to your nurse will will talk it over with you, and then they will go directly to the nurse practitioner, who will then help inform you, help make decisions, and then if necessary, we'll reach out to your oncologist from there, if that's the course of action that needs to be taken. But so topically, we have a lot of questions for you now, Kate, which you have answered for us in the past. But I think this is helpful for other parents to understand as they may go through this process, some of the things that are important.
Yeah, some of the common questions that, parents like us may have, coming out of the ICU, where you're told, medulloblastomas specifically, because that's what our son dealt with, don't really have any known cause at this time, and they tell you very little about the course of the disease. So you're just kind of stuck with how your child is presenting. Like, is this how all of them look? Is this the course for everybody that has to go through this type of cancer? So, we just kind of want to address some of the common questions that we had. The biggest one I'd say that we had when we reached the floor was that, we had to deal with the fact that there is a cause for medulloblastomas, and it's just that science hasn't figured it out yet. And
or,
it's frustrating.
Kate, have they figured it out?
Or have they?
Yeah, maybe you should tell it. Maybe you should tell us. Yeah.
Yes. No, I wish that they had figured it out. But no, we have not. Which is very hard, and it's the same for all brain tumors. If we knew what caused them, then we would be better at preventing them. Even if we know what may predispose a patient to a brain tumor, we know that we have to monitor them more closely, but we still don't have a way of preventing them. from happening.
So Inigo was diagnosed with a medulloblastoma. Let's just go to granularly. What is that, Kate?
So medulloblastoma is the most common malignant brain tumor of childhood. It's a tumor that requires multiple modalities to treat, starting with surgery, then radiation, and then chemotherapy. Overall, because it's an aggressive tumor, it's a very, aggressive, intensive treatment. There are four different molecular subtypes of medulloblastoma: Wnt, sonic hedgehog, and group 3 and group 4. And Inigo had group 4 medulloblastoma, which does commonly occur in older kids over 4 years old, most commonly like 4 to 15 years old, and slightly more commonly in males.
During those,
I didn't know that it was more commonly in males. Our difficulty, Kate, with what you're saying is that we are, as you know, we research things, we look into things, and Lindy, with her medical background, we knew what we were dealing with once the word once we were given the word medulloblastoma. So of course we went and we did our own research. The most difficult part of that. So you're saying that there's 4 types. We understood that. The most difficult part about it was needing to wait to find out what is the process that a parent has to go through, or the medical teams actually have to go through to figure out what type your child has. So in other words, Inigo was diagnosed and we weren't told right away. Why is that? And what is the process with that?
Yeah. So it does take time to make a diagnosis. The first step when the surgeons are in the operating room is they will call in the pathologist, and the pathologist will look at a small piece of the tumor underneath a slide, just to get an idea of what type of tumor it is. And really they're just looking at the cells. So they can say, okay, we have a small round blue cell tumor, which is what, under the microscope, if you were to describe medulloblastoma, that's what it looks like. But next, after they resect the tumor, then they send it off to pathology, and pathology has to cut up the tumor. They have to apply all these different stains and testing to it. And that all takes time. And that can take, anywhere up to 7 to 10 days. For the molecular classification, that can sometimes take even longer. And I think that's what we were also waiting for. We knew pretty early on, okay, it's medulloblastoma, but the molecular subgroup definitely weighs heavily on the prognosis. And that can take, sometimes it's coming back faster now, but if I was telling a family, I would say that can take up to 3 weeks to get that information, which is really, the waiting is, so it's hard for us. So I can't imagine what it's like for families.
Well, like us, like I said, since we research and with Lindy's background, actually, maybe I should put this into your basket here, but it was difficult for us because we were aware that there are different grades of each of those. So we have 4, but some are more treatable than others. Do you want to talk about that a little bit, just to give us an understanding, which is
Sure.
why it was so difficult for us, because we were anxiously awaiting of which one it might be, because it's not obviously anything that you want, but you definitely don't want to be some of them. And that's how we felt. Maybe other families wouldn't understand that, but it is something that we were waiting to know. Are we 1, 2, 3, or 4? Please don't be such and such. Sorry, go ahead.
Oh, sure. Yeah. No, the first group, the Wnt-activated medulloblastomas, those make up the smallest group of medulloblastomas. Only about 10 to 15% are the Wnt-activated group. And so the Wnt-activated tumors, those do occur in patients who are a little bit on the older children, like 7 to 14-year-olds. If you were to get a medulloblastoma, that's the one that you're hoping for. It has the most favorable. Number 2 is the sonic hedgehog activated, and that comprises about 30% of medulloblastomas, and that usually either occurs in infants or like teenagers, adults, so over 16. Depending upon those patients have an intermediate to high risk, depending upon other molecular features of that tumor. And then groups 3 and group 4, sometimes they're difficult to distinguish from each other, but we have gotten much better at distinguishing between group 3 or group 4. But if they're having a hard time, you may get a molecular diagnosis of group 3 or group 4. Group 3 and group 4 often do present metastatic. So you have that primary tumor in your post fossa, but you may have other lesions in your brain or leptomeningeal disease in your brain or spots in your spine, or tumor cells floating in your CSF. Which makes these groups traditionally harder to treat because there's more disease. Group 3 occurs primarily in infants. About 45% of infants with medulloblastoma are group 3. The prognosis overall for group 3 has the poorest prognosis. And infants, because they're unable to get radiation, have an even lesser overall survival rate of only about 20 to 30%. And then group 4 is, again, oftentimes those patients do present frequently with metastatic disease. And overall, it's the most common type of medulloblastoma. It makes up about 35% of patients with medulloblastoma are in group 4. In this group, overall, they consider it intermediate risk. Patients may or may not have MYC amplification or MYC-N amplification. If patients have MYC amplification, that does make it harder to treat. And with MYC-N, it was previously thought that also made it harder to treat or worsen the prognosis. But they're now learning a little bit more about that and able to distinguish. And it may not have quite as poor prognosis as we previously thought.
That's interesting. Yeah, I don't remember which classification Inigo fell into for the MYC activated or not, but
yeah, actually, I was looking that up, and I don't.
We know that his course of treatment was difficult.
Kate Matson.
Yes. Yeah, no, sorry, Kate. I do. And actually, I remember talking to you guys about it because we got it back and he was not MYC amplified.
Okay.
So, which I was very happy about and was reassuring. I said, well, that's one positive in this group 4 is that he's not MYC amplified.
I want to highlight something there. Parents that go through this, you're going to have certain days where you get information and you throw a party, and that's not normal for the general population, of course. But as Lindy and I were waiting to hear back, and that was so difficult for us, the waiting game of understanding. And then because we're both very researchy type people, we would look into things and read articles. And of course, we try to go to the best sources, the NIH. We're looking at the different hospital libraries and reading. And so when we were informed that Inigo had type 4, we threw a party in the room. I still remember Courtney was our nurse, and we were so excited. And you would think, like, why are you excited at the classification of your child? But we knew what the classifications meant at that time. We wished 1, but we knew it wasn't going to be 1. We were super scared about 3. We just didn't want to be 3. And of course, they're all difficult to deal with as a family, of course, but we didn't want 3. And so it's not that it felt like a win, but as you're saying, we felt very positive about, like, okay, we've got a chance. Yeah. And for anyone out there listening, one evening before Kate signed out, she came in to talk to us. And I think it was very, very early on in the process. It may have been the second day we were up on the neuro-oncology floor. And my concern was at the difficulty of the prognosis, of course. And Kate said something very important to me, which is, I think what I had voiced to you, Kate, was, why do we do this? You know, it's the idea that as a parent, you kind of want to, if you're going to lose your child, you kind of want the possibility to just rip the Band-Aid off, because you know it's going to hurt. You know, it's going to hurt you in so many ways. Why do we do this, Kate? Like, why do we fight? Why do we put a child through something where the prognosis may end up being the same no matter what we do? And I remember Kate looking at me, and I think it was the first time her medical voice like came off her timbre. And she said, well, we have to try. We have to try, because you never know. You never know what your child will respond to. You never know if your child's the one. And I think you said something like, and I know this isn't medical, but miracles happen. And I was just like, oh, lady, you're speaking my language. And I was so moved by that, because here I realized, like, in your heart, who you were someone that no matter what, you were going to fight for the best for Inigo and the best for us. And you were willing to communicate. Miracles happen, which I don't know if you hear often in the medical field, but maybe so. You know, you guys have conversations that we're not privy to. Oh. And so to hear you say that was like, oh, that feels good. And it's not blind hope or any of that sort of stuff. But as a parent, you always want a chance. Mm-hmm. You want your child to have a chance. So for you to say that for us very early in the process enabled us to grab hold of that rope that we didn't want to let go of anyway, because you don't want to let go of your kid.
Yeah, you're always looking for that hope.
Yeah, but it definitely enabled us to walk that. So yeah, going back, it's difficult to understand what subtype your child is into. I don't know if most parents are looking into the subtypes like Lindy and I were.
Because sometimes people just don't want to know. They're not ready to know. They already know their child has a brain tumor, and that's it.
And we respect that.
That's all that we can, someone can deal with at the time. And maybe that is all you need to know. Yeah. The rest, the team will, do their best to take care of and treat in the best way they know how.
Yeah, I've always said, I think one of the things that was most difficult for Lindy in particular is that she is a nurse. And so her knowledge and her connection with a lot of this sort of, and an oncology nurse at one point. And so, in adults. And
and I definitely had a threshold that I did reach a point at several points during the journey with Inigo that I just had to stop looking. What's the point for me? I didn't see any reason to go on looking forward. So I just wanted, to spend each day with my child, whatever experience that we had, we were going to have it. And that's what I live for each day.
But I can say, and I think Kate can attest to this, that didn't happen till the very end. Mm-hmm. Lindy was locked in. She was always like in lockstep with Kate about like information and going back and forth with the thought processes of Inigo's care. I don't know if this is in some of the questions that we were putting towards you, Kate, but how is it that you deal with parents that are more informed? Can that be a benefit to you? Is it something that you have to walk carefully? How does that work in the process? And maybe what can we do to help other parents if they're looking at this? What would you say to parents they should do with this sort of information?
I definitely think it's, if you have the knowledge, it's always a benefit. But I don't want parents who don't have the knowledge to feel like they're behind or missing something, because, the parents who don't have the knowledge, our job is to provide that knowledge to them and help kind of weed through whatever information they're gaining through any of the sources that they're tapping into. But parents who do have the knowledge, I only see that as a strength. And I feel like it strengthens our team being the medical team and the parents, because we're all, all one team.
We want to make sure, as we talk about this, exactly what you're saying, we want to make sure that parents do not feel any pressure to be anything than who they are. Mm-hmm. And if your sole role is to only be a parent to your child, just be that.
Yep.
All we're talking about is our particular situation and the fact that that Lindy is a nurse and what it did for us in our journey. In some ways, it was a curse. In some ways, it was beneficial. And as a person that is not connected in any way with the medical field as I am, I was so happy to see Lindy as an advocate in a different way, to see her and Kate and the team having conversations that I was like, yes, you're like the hype man in the corner in a boxing match where you're, and no one's fighting it out. That's not what I mean, but you're just the person that goes, yeah, those are good questions. Keep going. Like, keep asking,
And there are no stupid questions. Just ask them, right? I mean, how else are you, if you have questions, you need to ask them, especially in this setting. Mm-hmm. I think you'll be well received.
Yes, we welcome questions. And we always say that. And that's like one of my lines when patients are going home. Please call us with any question, any concern, because something that you may think is minor is major to us. So it's important for us to know, but also we don't want you sitting home or sitting in the hospital worrying. We want you to be able to talk through these things with us.
Yes. And
you have so much to worry about.
Your nurse practitioners are where you need to go to. And, we're going to keep saying that about Kate and her team. And that's one of the really special things about Boston Children's Hospital is you have a super, super strong team of nurse practitioners there that made us feel safe through this journey. And that cannot be devalued in any way. And it's very important for us to communicate that. Kate, we want to talk about posterior fossa syndrome. That, of course, is something that we explain to people when asked and in different talks that we've done, is that the general population has a vision of what a child with cancer looks like. We watch the Jimmy Fund stuff. We all get the St. Jude commercials. You see a skinny child, you see a bald head, or sometimes a puffy face, or, we all have an understanding. When it comes to posterior fossa syndrome, what we always say is you can add 1,000,000 to how you feel about a child when you visually see a child that has cancer. And the reason why we say that is because unlike in those commercials and unlike what you see in the Jimmy Fund telethon, you now have a child that in very many instances has a marker of not being able to communicate, has a marker of a handicap in much different ways than what you expected. And so with Inigo, we had a child that was super active in sports. He was highly communicative. He was
very creative,
tested as highly intellectual. emotionally intelligent, creative, funny, at a very young age.
Pretty mature for his age.
Understanding sarcasm, which is a marker that doesn't usually come to a lot later in life. And he's diagnosed with cancer, a brain tumor. We end up going through the initial processes. So tumor resection, and then from there we end up in medical instability very quickly. And then from there, 3 days later, we fall into posterior fossa syndrome. Very difficult for us as parents to deal with because, as we said, the things that you see out there in public do not tell you about posterior fossa syndrome. They show you what a cancer patient looks like. Posterior fossa syndrome does not come into your lexicon. Can you help us understand now, and parents that are watching, a little bit more about posterior fossa syndrome?
Sure. I feel like it's, in one word to me, it's devastating. You've already learned that your child has a brain tumor, and they go through the surgery. They wake up, and within the first 24 hours, they're able to communicate with you. And then all of a sudden that abruptly stops. The cause of posterior fossa syndrome is still not really understood, which is also frustrating. It occurs when tumors are in the post fossa, but also in the midline, which is very common with group 3 and group 4 medulloblastoma. They have seen that when the tumor is also invading the brainstem, that puts patients at higher risk for posterior fossa syndrome. But we still do not understand what the mechanism is that causes it. Obviously, it's something that occurs during surgery. They think that splitting the midline when they have to split or cut through the vermis in the cerebellum, that may contribute to that. But that's unavoidable because we know we want to get all the tumor out to give our patients the best chance of cure. So it's kind of like a risk benefit. And so patients usually within the first 24 to 48 hours after surgery, if they do develop posterior fossa syndrome, which occurs in about 25% of patients with medulloblastoma, which is not a small or significant amount, usually end up going mute. They're unable to, they're really the only vocalizations that they make are kind of a cry, continuous cry, moan. And it is a spectrum of severity from, lesser severe to more severe. And definitely, unfortunately, in Inigo's case, he had one of the most severe cases that I've seen. And he was unable to move when I saw him when he got to the floor. And he wasn't even really, opening his eyes that much. It was like he was locked in. And the time that it takes to recover also is very, very variable, depending upon the severity. So some patients may recover within a couple months, and others may recover but still have residual deficits for the rest of their lives. Not only the cognitive deficits, but patients have truncal ataxia. They're not even able to, at first sit up without support or even hold their head up as support without support. They require very intensive multimodality rehabilitation, which starts in the hospital. But most of the time, if patients are well enough, going to an intense inpatient rehab from anywhere from like 4 weeks, to a couple months is required with PT, OT, speech, of course, and also sometimes patients with the post-fossa syndrome, also they'll have trouble eating, swallowing. So that also is part of the rehabilitation. Yeah. But it's a long road, and it's a road that we don't know, and we don't know how long that road is going to be. Everyone recovers at a different speed. And we've had patients, on the floor, like Inigo, where, he was there for a couple of months after he came out of the ICU. And those days, they're so long. And every day you want to see them like making these huge improvements, but it really is baby steps. Mm-hmm. But every patient that I've seen, they do eventually get there. There is, some recovery and sometimes total recovery. But it's a lot of hard work for the patients, especially, as well as their, families and caregivers. Yeah.
Are there complications to the cancer treatment because of the posterior fossa syndrome?
I wouldn't say it affects, it would affect our treatment at all.
Okay. We wanted to make sure that we put that down as a marker so that people understand if your child ends up with posterior fossa syndrome, do not fear. They're still going to get the cancer care necessary. Yeah. We just wanted to hear you say that, Kate, but it's this idea that care continues. Yep. It doesn't stop.
100%. Yep. And I think sometimes, unfortunately, this is where we have to weigh care usually trumps rehab at some points. So that may be, it's essential to keep the patient in the hospital where they're not getting that intensive rehab that they would be getting at a rehab facility. But we have to keep them in the hospital and provide the therapies that we can while we start radiation and treat them with radiation, because we do not want to delay treatment, and we would not.
Yeah. And that is what happened in Inigo's case. Yeah. So Inigo, his case was so severe. Is that right, Kate? It was so severe that we could not be moved to therapy at that time, to physical therapy, occupational therapy. And Inigo began radiation therapy as soon as incisions were healed, and he was able to begin the process of radiation therapy. Yeah. And at that time, we would take him over to radiation lying in a bed. He wasn't even able to go in a wheelchair. So understand, parents, that sometimes if your child develops posterior fossa syndrome or CMS, their condition could be so severe that you may have to go through therapies in a state where your child's not necessarily active.
Yeah. And I remember at the time, too, they did have to wait until Inigo's intracranial pressures were more stabilized, that he would be able to lay flat inside of the radiation on the table so that he could receive the therapy safely.
No movement. Yeah. Flat on the table. Yeah. So that was important to us. Obviously, we understood the primary need for him to receive those therapies, and we obviously wanted physical therapy badly, because this was a presentation that didn't make sense to us, of course, but also understanding, as Kate walked us down the path of understanding, that the most important thing right now is treat the cancer. And we thought that was super important. Yes. Once radiation finished and that particular course, they enabled us a 4-week break. Mm-hmm. And in that 4-week break, I think it was literally like 3 days after we finished radiation, or 4 days after we finished radiation, Kate sent us right off to Spalding Rehabilitation, where we were able to start that next part of Inigo's journey before
therapy.
Before we came back to Kate. But Inigo's hands started working again before we left, and he was chopping people out of the room, and
he's able to give thumbs up again. It really helped with his yes/no answers. He was able to move his head back and forth, hold his head up, those sorts of things.
How difficult, Kate, is it for you as a team to deal with non-communicative patients?
I mean, it obviously it has its challenges. And I think we rely heavily on their parents or their guardians, caregivers that are at the bedside who know them so well. Because you're able to tell us, well, the way they're smiling or the way they're grimacing or the way they're, their face isn't relaxed. Maybe they're uncomfortable. Maybe they don't like what we're doing. So I think that helps with the challenge. I think also our speech team, our augmentative communication team, is very invested in caring for these patients, and I feel like they're also very helpful in kind of getting us over some of those communication barriers. But for me, I think the biggest help is the people at the bedside that are supporting the patient who know them so well.
Awesome. Thanks for saying that about us.
Well, I feel bad because I feel like sometimes maybe we're putting a lot on the parents or the caregivers at the bedside. But I can't stress enough how much we are all a team. The medical team and the parents or the caregivers at the bedside, and we wouldn't be able to take good care of the patients without them.
We try to stress to parents, anybody that may be listening to this, you have to be super involved in your child's care. You can't just hang out on the couch. You can't go to do stuff constantly. You need to be the most active person in your child's care, regardless if they have posterior fossa syndrome or not. This is a journey that percentage-wise may not end where you want it to end. You want every minute that you can out of your child. Yeah. And we're saying that, Kate, as parents, I don't know if you would put that on parents, but we want to let parents understand how important it is for them to be active role players in their child's care.
Mm-hmm. Absolutely. And we want to encourage that. We know that there are going to be some days where you are just exhausted and mentally, emotionally, and you just need a break. But yeah, if we could just encourage you to keep pushing forward, find the help that you need maybe, and get yourself involved in all of your kids' therapies.
Because your child doesn't get to take a break from having cancer.
No.
So,
I would say don't be afraid to ask for help. And ask for resources. Yeah. Whether you're at a smaller center that might not have as many financial resources, but definitely at state and national levels, there are foundations and other resources that can help families.
Yeah.
Yes, absolutely. Look for those. Get your social worker involved. You need the resources that they have.
Yeah, they can help you along
reach
that
out
path.
to Amar.
Yeah. Yeah. So one thing I want to just talk about before we move on from this is about some of the complications, just to let parents be more aware that complications do have the potential to evolve. They may not. But I just want to highlight some of Inigo's complications that he did have, after the tumor was removed, or in just having medulloblastoma itself, what complications it caused for him in his recovery. We talk a lot about the 3 weeks in the ICU and then the early weeks on the medical floor and what that all entailed and how hard it was. Those things. We just want parents to be aware of what happened with Inigo, because it could be a potential for them, or if they are actively seeing this in their child, that it has happened in our own son. Namely, after surgery, Inigo had to have 3 brain surgeries very early on to address the pressure in his head and his skull. So he did eventually have to have an EVD again, the external ventricular drain. And that was, it was quite a thing to manage for a little bit. And then he was eventually able to get a shunt put in, which helped relieve that pressure in his head. But during that period, he did develop an issue with being able to eat, being able to tolerate tube feedings, because he was not able to swallow, like you had mentioned, Kate. It does affect those nerves. He had to have tube feeding. So he wasn't even tolerating the tube feedings very well. He did have a lot of problems with constipation, and the triad of having tube feedings and radiation and steroids. It made things very, very hard for Inigo and his digestive system. He did develop what was called pneumatosis at the time, where bacteria had gone into certain layers of the large intestine and started making gas and bloating and causing him a lot of pain. So we knew something was wrong. So we realized that, this is not going to happen in every case. But this did happen to Inigo. Can you talk a little bit about how medulloblastoma may have caused this cascade in him?
And in most kids that do develop complications, why does medulloblastoma and where it is in the brain cause a cascade of issues down the road?
Mm-hmm. Well, I think there's multiple layers. Mm-hmm. I think that the pneumatosis that he had was probably a result of the radiation and the steroids. We know, steroids effect can make you immunocompromised, as well as he was getting radiation of his brain and his spine. And he does get, when you're getting radiation of the spine, there is some scatter to the gut. So I think, and we were using the steroids because he still had a lot of swelling, postoperatively in disease. And when you start radiation, when you're radiating active disease, you can actually cause more swelling initially. So that's why he was on the steroids. So I think the steroids and the radiation were probably the cause of the pneumatosis. I think anyone who is as sick and as immobile as Inigo, or patients with medulloblastoma when they have posterior fossa syndrome, obviously puts them at high risk for constipation. When you're not moving around, your gut automatically, slows down. And patients who, thankfully we were still able to slowly feed him enterally, but patients who are immobile and on tube feeds, they're automatically at high risk for constipation. Mm-hmm. And obviously he had all those complications because of the medulloblastoma in the posterior fossa syndrome.
Yeah.
Yeah, complications arise, and that's pretty much what we want parents to also understand is that, once again, like you're dealing with a primary diagnosis of cancer, but there are so many things that arise. Yeah, go ahead, Kate. Sorry.
Oh, no, I was just saying so many layers.
Yeah. There's so many things that end up happening because of whether it's treatment, whether it's the cancer disease itself, or your child will end up on a lot of medications that also have serious side effects and complications. that we must say that the medical team does a really good job at sticking and moving to try to hit those little gophers as they pop up, but it is a situation that you want to actively be communicating with your team about what you're seeing, especially if you're in an outpatient setting. For instance, you're going to see a lot of things at home. You're going to be, there's a lot of stuff that you want to communicate with your team so that they can help you, take care of those pop-up issues.
And like I said, we don't want to be alarmist about this, about, complications popping up, but we just want patients and families to be aware that these things come along with the territory, unfortunately. And like you had said, the team does a really good job to prevent as much of this from happening as possible, in terms of infection and, other things that just commonly happen when you're being treated for this type of brain tumor.
Yeah, complications arise. Kate, you guys do a wonderful job at helping us figure that out and communicate that. So I could thank you 1,000 times about it, but I think it's really important to understand, the nurse practitioners really are on top of this situation. And especially for a system that is essentially chaired by your nurse practitioner team, you are who we went to and for answers for a lot of things. And you guys did a wonderful job, like I said, either researching what our concerns were about or just answering our questions. So we appreciate that. Something that we also want to get into is in the process. You very many times we describe it as a 3-part process. There's a beginning, there's a middle, and then there's an end. And we like to say it's the ending of the plane phase. As you help parents enter that last phase of their child's care, what are the things that you are looking for as a medical caregiver to do for both the child and the parents?
I think the most important piece as a provider is meeting the family where they're at. I think that sometimes as providers, we may have an idea or we may, have a strong opinion of where the patient's at or where the family's at or where they should be at. But I think that what matters most is recognizing where the family's at and meeting them there.
Yeah. For one of the things that we want to say as parents that have reached the end of our journey with our child, the care received through the entire journey will inform what the ending is going to look like. And so if we as parents can make this entire journey about your child's needs, that will walk you naturally into a position at the end of life where it's also focused on your child's needs. And that's very difficult to say because, of course, as Lindy was saying, and something that we've talked about in the past, is you're going to be going through your own emotional journey at that point with the realization of the ending of all of this. But it's really, really important for you to hold your child's hand through that very last part. And Kate, what you all did as a team for us was to enable us to be wholly connected with Inigo. And from that point on, you took medical decisions out of Lindy's hands. You took those conversations out of what we were doing, and you made it about giving us that personal time that was necessary, even though we were in a hospital setting. And that's important for parents to understand. Your team will do for you. Your nurse practitioners will make sure that people know your monitors don't need to be on anymore. You don't need to pay attention to telemetry or what your child's heartbeat is doing anymore. You just need to focus on being with your child. Is that how you would inform it, Kate?
Yes. And I wish that, I think we can do a good job of that in the hospital. And I wish that there was more supports so that families, if they wanted to do end of life at home could do end of life at home more often. But I feel like that is usually one of the biggest reasons why families decide to stay in the hospital for their patients' end of life, is that the parents say, I just want to be their parent. I don't want to be, administering their medications, trying to assess, what do I treat this symptom with? I just want to be there holding their hand. I just want to be in their bed, and I want the medical team to handle everything else. I just want to be their parent.
Yeah. That was pivotal for us. Yeah.
Mm-hmm.
It was.
Thank you for giving that to us.
Yeah, thank you for giving that to us. You were witness to how we walked this entire journey with Inigo, and we were hyper involved. We think that was the right decision on our end. We were hyper involved with asking you and Callie questions that were difficult for you to answer at times. But you enabled us to be who we were, just as I'm sure you enable other parents who are different to be who they are. And at the end, when you would walk in there and just sit with us, and we would just look at Inigo in bed, and you would talk to us, it felt like you truly cared about who we were as people and the journey that we were going through. You are such a medically intelligent person. I'm sure intelligent person all around. But your kindness and your empathy for us and what we were going through really came out at a much higher level. You were always empathetic through our entire journey. But at that point, you didn't hide anything from us, I think, in how you reacted to what we were going through. And for that, we are appreciative for those moments that we got to talk to you and got to hug you. I still remember you walking in. I think the thing is, these children, as they get to the end of life, a lot of their bodies are still very strong. Their hearts are strong, and it's like their body doesn't want to give up. And so Inigo fell into almost a coma of sorts, and his body didn't want to give up. And what it meant is that was a long journey of 11 days that felt like years of us watching him, waiting for that last moment, that last breath. And I still remember I was in the hallway for something. I think I was grabbing Lindy some sort of sustenance that she needed to have. And Kate came in that, for the morning and, just looked at me with the biggest tears in her eyes and just gave me a big hug. And she said, they're just so strong. And it was exactly what I needed to hear in that moment, because you're losing your child. But it was actually the words that you used that meant so much to me, is that, yeah, that's right. Inigo is strong. And I hate to get emotional. It's obvious why I'm emotional, but yeah, parents understand your kids are strong. And, they reach the end of this road, and it's not for anything that you did as a parent. We raised Inigo. He was a healthy eater. He exercised constantly, even through having kidney disease. And, it was nothing that we did that Inigo ended up with cancer. And so Kate said to me, he's just so strong. And it was, oh man, Kate, is the words I needed to hear. Because I knew that. But I think with any parent, you want the world to see that your kid's a rock star, And when you said that to me, it was like, Kate, I love you. Yeah. Yeah. Inigo is strong. But anyway, gosh, I hate ending these on an emotional note. Kate, we appreciate you and what you did for us. We appreciate what you do on that floor. It's like we always say, you are a superhero, and the things that you do and the things that you enable your team to do is very, very important to us. And as we would always say to you, please keep doing this as long as you can. Eventually, we know that the emotional toll of this sort of stuff can't just go forever for you guys. But, and it's great you're at a teaching hospital, because the young ones come in and maybe they don't know what to expect, but, you really teach them and enable them. You and Callie are really the markers of the nurse practitioners on that floor. And we remember in the ICU being told about who you were and how excited we should be to have you next in our line of care. And man, we found that out when we got onto the 9th floor. We were super stoked and excited. And we knew that we had somebody that was in our corner. As people, Lindy and I, of strong faith that we are, we almost felt like you were a partner in that faith. And that meant a lot to us too. That's not what this conversation is about, but we felt that in you, and we appreciate that. So once again, I'm going to reiterate for everyone, please understand that nurse practitioners are going to be, in very many ways, the backbone to your medical care team. And they are going to be your voices that you can reach out to in concern. And it is important for you to do so and to really understand that they will be your advocates for a lot of your child's care. Make the most out of every day with your kid. Your team will allow you to do that. In fact, they will encourage it. Is that right, Kate?
Yes.
I'm going to leave one last thing here. Don't be afraid to make Kate stay in the room and talk to her. I think Kate would walk in for a 15-minute set of rounds and she'd leave 45 minutes later. Because Inigo would turn to me. Oh, by the way, for anyone listening, Inigo did end up talking. He came out of being mute. He could walk. He could, there were major complications with his therapy, but he really pushed through. One of the things that we push on this podcast is therapy is your friend. Mm-hmm. And so Inigo walked, talked, ate good food,
had a really good recovery.
Had a good recovery from what we feel. He wrote books. He told jokes. And like I said at the beginning of this, introducing Kate, Kate was one of the last people that came in to see him when he was still talking. And she came in because it was the end of her day and she was going home. And he just wanted to talk to her. And Kate, I don't know if you remember that, but it's a vision that we have in our heads, and we talk about it constantly, about how he particularly looked at you and zeroed in that he wanted to talk to you, mm-hmm. which speaks volumes to us about how he felt about you. And so he made sure to, and I remember you bending down at the bedside and listening to him, and I don't know, an hour, 35 minutes, an hour, I don't know what it was.
A while.
Yeah. So
yeah, I will never forget it.
Yeah. So even though he used to say, Dad, you talk too much. He did that to you, Kate, at the end.
That day he took over.
He did.
Kate, thank you. We appreciate you. Thank you, Kate,
Thanks,
for everything
Kate.
you do.
Well, thank you so much for reaching out to me and including me. I loved talking with you. I think that, you ask how can I keep on doing this for all these years? And I just always tell myself that, I can't change, unfortunately, I can't change the fact that my patients have brain tumors. But there's a lot that I can do and a lot of changes that I can make to make every day the best day that they have while they're dealing with this. And I think that's what keeps me going. And then the other part that really keeps me going are the families like you guys and the patients.
Thank you, Kate.
Like Inigo, because not only do the patients and their families shape my practice, they shape my entire outlook on life. And they make me a better provider and a better person. So thank you for appreciating me, but I truly appreciate the both of you and Inigo with all my heart.
Thank you, Kate. Gosh, Kate, you always put it better than we do. No, it's absolutely, yeah. I think that's really, really important. So something that you said, and I know we're signing off here, but something that you said, we may inform you and inform the things that you do. You informed us. You enabled us to walk this in a way that was grab that bull by the horns. And that's really, really important. So thank you for allowing us to help you, but thank you for helping us. It is incredible how much we need people like you. And we'll say it over and over and over. If you are a parent with a child in the hospital dealing with this, you need a Kate. So if you're not at Boston Children's Hospital, you need to go identify who that ally is on your floor and make them understand that you need them. And as Kate is saying, maybe that will inform their care for you. So thanks, Kate.
Thank you.
Thank you.
That wraps up our show for today. Thank you for being part of the conversation. We hope that by listening to our discussions, you can find valuable information. If you believe that the Love is the Cure Foundation podcast could benefit someone you know, please share our content and support our cause.
Our desire at the Love is the Cure Foundation is to help children and families as they navigate a pediatric brain tumor diagnosis. Our experience is with Inigo's brain cancer diagnosis. Some of our conversations may be specific to brain cancer and the residual effects. That being said, through these conversations, we hope to impart practical information that may be useful to a family that may need it as they journey with their child through a pediatric cancer diagnosis, brain cancer or otherwise.
We are a nonprofit charitable organization. If you would like to donate to help the Love is the Cure Foundation, please go to our website, loveisthecurefoundation.org, where you can donate and also read about our story and the outreach that we are doing at the foundation.
Visit our website to find the link if you're interested in purchasing Love is the Cure shirts. We're thrilled about our new design, which includes many Inigo elements. Thank you to everyone who has already bought a shirt. Every contribution matters as we strive to support our pediatric cancer community.
Thanks for checking us out. Go love on someone. We all need it.